Good day. My name is Kevin Adams, and I'm the Chief Technology Officer for EdFX. We're here to talk about why clinical integration has become such a popular thing for payers. And that's because care management and clinical interventions have classically been determined by claim and pharmacy data. This has been largely because that was the only data that payers had access to in the past. The problem is that this data tends to be very retrospective and in arrears to an actual episode by some 30 to 90 days, largely due to claim submission process as well as the adjudication capabilities of the payer. And the key issue is that if you're going to have a chance at changing the behaviors of both the patient and the physician, you really need to have them be aware of the needed actions in a much more real-time basis. A simple example of that would be where a patient is admitted to a hospital where there's a need for a very coordinated discharge plan. Unless the payer is notified of this event through either a pre-authorization or a clinical feed, they would have no idea that this episode had occurred, and when this claim was submitted, the patient would have long exited the hospital. By leveraging clinical data, population health can be done on a much more real-time basis. Instead of waiting weeks for claims to be submitted, processed, and then analyzed in a payer's warehouse, you now can leverage an HL7 feed to understand the clinical activities that occur for a member on a day-to-day basis. This is very important because as payers fight to lower their medical and administrative costs, this has become one of the most desired tools for helping them coordinate the care with the physicians, which in turn helps lower the medical costs. Population health is one of the payer's business use cases which benefit from clinical data, but there are certainly many other business processes within a payer which can realize similar benefits. An example would be the risk adjustment process, which can drive higher reimbursement rates from the federal government. Clinical data helps the process by having a better understanding of the clinical events which occur around a member's life, which in turn helps the plan better understand the correct actions have been taken for that member. Other examples exist, such as ACO management and medical necessity processes. The single largest challenge has been the lack of aligned incentives, objectives, and frankly, trust between providers and payers. There is a bidirectional need for information sharing because doctors need the claim data to see the complete picture of the patient's medical usage, and the payers in turn need the EMR data in order to have a timely picture of the member's activities. Through incentives, shared savings programs, and ACOs, the providers and payers have begun to figure out how to share this critical information between each other. Now each party needs to figure out the physical mechanics of how to ingest this data and, frankly, what to do with it once they have it. HL7 standards have been around for many years. It has primarily been an interoperability standard between EMRs, and it lacks the field-to-field rigidity which is found in the HIPAA standards, which the payers are most comfortable with. This lack of content normalization and process automation can cause payers to ingest confusing information which hinders the objectives which they are trying to achieve with this data. An example of this might be where an HL7 message comes in and it frankly does not have the information needed to properly attribute it to a member or a provider. This is a very common process in claims processing which has been mastered by the payers for many, many years. So while all payers realize there is a significant value in leveraging this clinical information, most who have rushed into digesting this data have found that they have large quantities of relatively useless data in their warehouses. They're now going back to figure out how they can normalize and correctly identify the data at the point of ingestion into their companies to ensure that there is greater usefulness of the information once it goes downstream. So what's next for payers? If HIPAA data today represents 100% of the data that they currently ingest, so 837s, 834s, 270 transactions, you can expect clinical information to be something on the order of 10 times more data that they're going to need to process. While that may be somewhat of a scary number and factor, I believe that we are about to see an absolute explosion of data when payers begin to look at things like medical device information, Fitbit or other wearables, and even genome data. This explosion will likely be somewhere on the order of 100 times the data that payers currently are processing. Additionally, there are limited or no standards around these new types of data and their sources. What used to be a simple HIPAA transaction will need to evolve to what we call digital health data interoperability standards. This will be a massive quantity of data with varying structures and content. To gain the benefits of this real-time information, payers will need to implement solutions which understand how to digest, align, and normalize the content to make that data truly actionable. The current cluttered and cumbersome retrospective warehouses that we see today are going to be supplanted with on-the-wire, real-time engines which allow health interventions to be delivered in not just real time, but with increased accuracy. This is what I believe the future of healthcare data interoperability will be.